Good afternoon, everyone. I'm just going to give people a couple of minutes just so I can see the numbers of participants joining going up. So I'm going to give everybody a little minute before we get started. Okay, people are still coming in, but I shall get started with some introductions and some opening remarks. Uh, Hello and thank you so much for being here today. I'm Kirsten Horsburgh, CEO of Scottish Drugs Forum, and I'm really pleased to welcome you to this webinar today, Personal Journeys, Collective Care, Recovery Communities at the Intersection of Support and Strategy. This conversation is important and overdue, not just because of the work we do, but because of how recovery has been shaped, framed, and sometimes limited by the narratives we've inherited or indeed created. We often talk about recovery meaning different things to different people, but what do we really mean by that? That flexibility can seem vague or even frustrating to some, but surely that flexibility is the whole point. Recovery isn't one path, one definition, or a destination, and yet too often we've allowed the word recovery to be narrowed, tied tightly to abstinence, and used in ways that unintentionally exclude people who are still using substances or who don't fit a fixed model. And recovery is too often seen as something that only begins after someone has stopped using, rather than a process that can and does happen throughout a person's journey, including while substance use is still a feature. If I'm honest, at times I felt uncomfortable even using the word recovery. It felt burdened with negative connotations that left little room for nuance or individuality. I've always really admired the Chicago Recovery Alliance, a pioneering harm reduction organisation whose guiding motto, any positive change, really encapsulates their entire philosophy. This principle recognises that every individual is the expert in their own life and that even the smallest steps forward in health, safety, or self-determination matter. And for someone using drugs, that positive change might be choosing to use sterile equipment. It might mean carrying naloxone, reducing their use, or attending a support group, but it might also be about sleeping indoors, reconnecting with family, seeking mental health care, or simply surviving another day. This motto challenged the abstinence only narratives dominating recovery in public health spaces. It offered a more realistic, inclusive, and person centred approach, one that saw value in progress over perfection and dignity over judgment. And this approach is a reminder that supporting autonomy and small steps can create the conditions for long-term meaningful change. So today's discussion is about broadening our thinking and asking, what do we actually mean when we talk about recovery in Scotland? Not just a service, not just a meeting room, but opportunity, relationships, dignity, belonging, and community. So we're going to explore how recovery communities in their broadest sense can move beyond the harm reduction versus abstinence divide and instead focus on what actually supports people: connection, compassion, and choice. Thank you for joining us. I'm really looking forward to the conversation. We have three fantastic guests with us today who I will introduce in a moment. They'll each have 10 minutes-ish to talk, and following that, we'll have time for Q&A. So please submit your questions throughout, and we will do our absolute best to get to them at the end. So without further ado, I would like to introduce my colleague Wes Steele from Scottish Drugs Forum. And Wes, I'm going to stop talking and pass over to you. Thanks very much.
Thank you very much, Kirsten, and thank you for the opportunity. Thank you to the panel, and thank you to everybody who has taken the time to log in and join the webinar. Such big questions, stuff that's really kind of close to my heart, and stuff that I've struggled with, I guess, and stuff that I reflect on quite regularly. You know, if you'd have asked me, I don't know, 5, 6 years ago, maybe, when my recovery started and how I defined recovery, I probably would have said a cessation of my drug use and stopping my drug use. And that's not true. That's not accurate. You know, I engaged with harm reduction services probably for decades before I even contemplated reducing substance use, and certainly had no notions or ideas around completely kind of stopping. So what does it mean? And I think it's really important to try and, I guess, come up with some widely accepted definition, but flexible and inclusive enough. I like, you know, the Chicago Recovery Alliance's kind of definition as well. I guess for myself, it's any step towards healing, or even reframing that as any kind of movement towards improved well-being. And, when did my recovery truly start? And I have mulled that over, and I guess I've moved when I think it started back and back and back. The kind of more I've mulled it over and the more I've been involved in different models and different versions and listened to many, many different people, often not all who I agree with. And I love that. I love spending time with and being open to dig into some of these topics with people that I don't wholeheartedly agree with. And I think that's really quite healthy to be doing. So I think, when did it start for me? Being roused from an overdose and not being really, really disappointed and mortified that I was still here is one maybe time point. Not sharing injecting equipment, not thinking that rough sleeping was okay, and realizing that I could and should and worth a kind of bed. So yeah, I think that for me would definitely be a defining factor and a kind of milestone, I guess, that kind of very, very early initial kind of sense of self-worth or wanting to be here and things like that. And it makes me think about a lot of interactions I've had with services, professionals, specialist services, even just people that have tried to kind of help me over the years. And I think there's something really important about trying to frame things in this strength-based approach. I remember engaging with services for so long, and what was the starting point? What is the starting point for the person whose definition of recovery we're kind of talking about? Because that's so different for so many people. And I remember going to various different appointments, especially often with prescribers, if I'm honest. And I might have been able to not offend for a while. I might have, been able to secure accommodation. I might have been keeping appointments with other services and things like that. But I would often leave those appointments feeling really disheartened and dejected and like a failure because my urine analysis had come back positive. And that for me, I didn't realize it at the time. I didn't know a lot of this stuff, I guess, or even think about it at the time. But that for me is really quite telling. And I think, it's a disservice to people that we're trying to support to be gauging how we think they're doing, and I think, I often gauged myself in how I thought I was doing on, if I was using illicits, what dose of medication I was on, rather than, what is my well-being like? Is my well-being improving? Is my mental health improving? Am I eating? And various kind of things like that. I'm often asked, or I've been asked, maybe often is a stretch, but I have been asked in the past, how do I reconcile doing harm reduction work when I, in my personal life, follow an abstinence-based model of recovery? And it was quite surprising to be asked that. And I was almost taken a wee bit aback, of more surprised that anyone thought there would be a conflict there, I guess. And maybe this is just my perception of it, and maybe others, don't see it that way. But for me, the values are and should be the same. We talk so much about being person-centered, and I believe that a truly person-centered approach is really quite difficult to implement. It's really very difficult to commission and fund and things like that. And I think leading folk towards outcomes they might not have asked for, to me, is inherently dishonest, and it breeds mistrust, and it often invokes counterwill. But I believe often that's the way services are commissioned and set up and designed, is to be trying to move people that are coming forward for support towards an outcome they might not have even identified they wanted. And I think personally that's one of the struggles we have, or one of the kind of issues we have. Um, Again, I've been on a journey and my perception has changed massively around a lot of stuff. If you'd have asked me 4, 5, 6 years ago, I would have been a real strong advocate for the model that I've chosen to follow. And I would have been naive enough to think if everybody did the steps that I did, they would get the outcomes that I got. And I know very, very differently to that now. So yeah, I guess it's about trying to really truly come alongside the people we're trying to support, I guess. And I love recovery communities. I love unfunded mutual aid. I love all options on the table for everybody. But I guess, how do we make them more appetizing, for want of a better phrase? Maybe that's not the best word, because I know, and I've worked in abstinence-based services, and I know there's a balance to be struck between providing a safe and secure environment for people that may be quite newly having stopped using or reducing using, and things like that. But how do we balance that with encouraging and providing a space for people that might be having some of those early thoughts about maybe they do want to start trying to reduce, or maybe even, you know, have the idea about, is stopping even possible? I know for me, for decades, I thought it wasn't. You know, I really thought it was unachievable for someone who used and lived the way that I'd kind of lived. So I guess it's, you know, for me, how do we balance that and create a no wrong door kind of approach or community aspect for people while catering to the um, different populations that have come in? And it's quite a difficult one, I think. I think there's no maybe clear, easy answer, and I'd be keen to hear, you know, if any of the other panelists have got a thought on that, or if there's questions coming in and stuff like that. Yeah, I love this sort of topic. I really do love this sort of topic. I want to just say and be very, very clear that I don't profess to speak for groups of people and populations of people by any stretch of the imagination. This is just one lad's interpretation and one lad's kind of perception and change in attitude around what I think recovery is and what I think it means. And you know, it's important to have some common terminology, I think, so that we, for ease of communication, and I believe lots of services and lots of organizations and people are moving in the same direction, but might be choosing to use different language, or, you know, for want of a better phrase, kind of falling out or contesting language. And I think often that can detract us from the kind of greater good that we're kind of working towards. Yeah, so I think, if I'm honest, Kirsten, I think I'm probably drying up a wee bit. I've maybe not utilised my whole 10 minutes. If there's any minutes going begging after the rest of the panel, I might have some other kind of thoughts. But I'm really, really grateful and privileged. I do feel very privileged to just be able to even contribute my tuppence worth, and it is just my tuppence worth. But yeah, I do feel very privileged to be in a position to do it, and hopefully I've conveyed some of my thoughts in a manner that people can understand. Thank you.
Thanks so much, Wes, for your like really thoughtful, authentic reflections there. And I'm sure you'll have way more to say as well in the panel discussion and the questions towards them. So thanks so much for that. So I'm going to pass over to Tracey McFall now from Scottish Recovery Consortium. Thanks, Tracey. Over to you.
Thanks, Kirsten, and thanks for having a space where we can actually discuss some of the things that we've been grappling with, I suppose, in Scotland for a number of years around recovery. So I have got a few slides. I won't take long. And my colleagues at SDF are going to share those slides for me. And for those of you who don't know me, my name's Tracey McFall. I'm Chief Executive of the Scottish Recovery Consortium. And I suppose part of the grappling that we've had in Scotland when I came into post is we really wanted to start to talk to recovery communities and lived experience organisations about some of these discussions and challenges that were coming up. So move on to the next slide. My colleagues are going to help me with the slides, folks, and it won't take long. So as I came into post, we, as an organisation, we really started to think about, well, actually, what does recovery mean for Scotland? Where's recovery fit in? Where is the discussions around recovery? So we've done a piece of work last year around just really talking to organisations, lived experience organisations, recovery organisations in Scotland. And the reason why we wanted to do this work is because SRC, and I've been really candid here, hadn't spoke to communities across Scotland for some time. So we really just wanted to get a sense of where they were at. We don't really have a baseline in Scotland in relation to what that recovery space looks like in terms of recovery communities, all shapes and sizes, and lived experience organisations. Quite rightly, in relation to the national mission, there's been a focus on treatment, and I think treatment is an option for a range of people, and that is absolutely okay, and that's a choice. But what we also wanted to do at SRC was to look at, well, actually, what else is happening in that treatment space, but focused on recovery. And some of the work that we've done has really helped to shape how we want to go forward as an organisation. So how did we do it? We connected with alcohol and drugs partnerships, recovery communities and lived experience organisations, and we've done a deep dive across 5 areas in Scotland, including 2 rural and remote areas. And how did we do it? We've done surveys, we've done follow-up, and we've done local face-to-face meetings with a range of organisations and ADPs across the country. So this is what we've started to find in relation to the snapshot that we took across Scotland. So we engaged with 50 recovery organisation LEROs and 41 engaged ADPs. And we've really started to see, I suppose it goes back to what Kirsten said, we've really started to see the range and depth and differences at that community level of how recovery communities are structured. And that might mean just people sitting around the table having a cup of tea, 5 people getting together. It could be constituted groups. It could be really big lived experience organisations. So what we really started to discover is there's a range and depth and diversity of recovery that's embedded in our communities. We identified that a third of them were charities, a third of them were constituted, a fifth of them were constituting groups, and a third of them were part of a bigger organisation. So a real diverse range of where we're connecting and engaging with recovery communities across Scotland. For the ones that we spoke to, there was 29 recovery communities identified at 129 staffing posts. So that's a chunk of the workforce that are actually connected into the treatment systems, connected into the bigger systems, and are actually supporting people in that recovery pathway. Now, some of the stats that were found in relation to this has blown my mind, actually. So 3/4 of the people in the areas that we spoke to, recovery communities in Leros, they had 400 volunteers. That was 27 communities we spoke to, 400 volunteers delivering 2,800 hours per week. Now, that is a massive chunk of the workforce that's contributing to the national mission in reducing drug and alcohol-related harm. So that's 400 volunteers delivering 2,800 hours a week, and just let that hang there. And what we've also found is the organisations and communities we've been speaking to, the funding ranges from 2,000 very small pots of money to massive investment from alcohol and drugs partnerships in relation to integrating recovery into treatment systems. Over half have received ADP funding, and that gives you a sense of the range of the funding. And 2 recovery communities we spoke to are 100% reliant on ADP funding, and half that we spoke to do have targets and outcomes linked to funding. Next slide, please. So we did start to, I suppose it's the same question we've asked SRC that Wes and Kirsten and I as national organisations are asking ourselves, well, what does recovery mean? What is recovery communities? How are they defining themselves? And these are just some of the words that come up for recovery communities and leaders when we ask them that question. It's about that community connection. It's about hope. It's about social interaction. It's more than treatment, but being involved in treatment if that's what people choose. And it's to meet people where they're at. It's asset-based rather than deficit-based. And that was really, really come out loud and clear. And there was something around how recovery communities and lived experience organisations are linking in to those bigger systems around employability, health and advice. And one organisation, one community we spoke to actually does a lot of work around early intervention and prevention and can get access to treatment a lot quicker than statutory services because it's linked straight in relation to those people who relapse. So it really gave us a sense that recovery communities and LEROs are not attached to the end of treatment. They're integrated into communities and into the systems that we would call as part of that treatment system. Next slide. I've only got a couple more slides left. And we asked recovery communities and LEROs, what do you provide? Now there's another stat here. So the 39 organisations that responded to this, they support 2,200 people per week. So if you multiply that across the year, LEROs and recovery communities, as part of the discussions that we're having today, are supporting a massive amount of people. Now, those people might be engaged in treatment, those people might be engaged in harm reduction activities, those people might not, they might be completely abstinent. So this kind of work has showed us that recovery and that recovery pathway, that recovery system is actually really quite integrated into what is currently being connected and delivered across the country. So peer support groups, one-to-one support, social events, training, alternative therapies, access to treatment pathways. They offer a range of support and activities, and I think that's really quite helpful to identify that recovery communities and LEROs are not just attached to the end of treatment pathways, as Wes said. These are integrated in every part of people's journeys. And again, these are the range and benefits that people have told us about. So again, ADPs have indicated that recovery communities, recovery pathways are really important in relation to that recovery-orientated system of care and treatment. But food was a big part, health and wellbeing, social connection, the stuff that Kirsten talked about. This is about connection, compassion, it's about asset-based approaches, about meeting people where they're at. And that came over loud and clear in terms of some of the benefits and impacts. What we also identified is, just in terms of building on some of the discussions I've had, that 40% of the organisations and communities we spoke to have a structured pathway alongside that treatment. So, and I think that's really, really important to highlight and identify that, and I suppose this connects with some of the work that SDF do around the addiction worker training programme with us about those pathways if people want it out of treatment, if that's what they choose. People may choose to stay in treatment, and that's okay, but some people would like to choose to come out of treatment. So where are those pathways out? And 40% of the organisations and communities we spoke to provide that. And they're also connected into those broader employability, advocacy, homelessness, BBV, health, harm reduction services that people are accessing to reduce drug and alcohol related harm. This is just a very small quote in relation to something that really stood out for us, and that's really just, as someone said, that recovery communities and LEROs are actually just meeting them where they're at, and it's really helped that routine alongside their treatment. So that's just part of that broader pathways, and ADPs are seeing recovery communities as part of that vital pathway. One of the reasons we've done this, and I'm really conscious of time now, is we, as an organisation, SRC really wanted to try and understand what some of the challenges were for recovery communities and lived experience organisations across Scotland. And some of the things that have come up are funding. Post-2026 national mission discussions are currently taking place, but what does this mean for Scotland? And it's really timely, this discussion that we're having as a sector about what recovery means and where that fits. There is clearly identified issues being highlighted by recovery communities and leaders around recruitment, capacity, retention, those underlying issues around poverty and inequality, and that was really clear in the work that we've done. And ADP's also recognised that there potentially is some work that we need to do around future funding of recovery communities and lived experience organisations. So recovery in our communities, what we know and the work that we've identified, and those who work in recovery communities on this call will understand and know that they're deeply rooted in communities, and they are embedded in their communities, and they should not be seen as an either or. And this is not about treatment versus abstinence versus harm reduction versus recovery. This is about choice. This is about making sure that people have access to what they need, and that could be a range of different things across our pathways. They do have a critical role in supporting people affected by drug and alcohol harm, and that's come over really evidently. And actually, people in recovery communities and leaders want to feel valued in this space. They want government, they want us to recognise that they should be acknowledged in this space because they have a part to play. And actually, in addition to that, there is a range of harm reduction and prevention approaches and services and links into recovery communities that they're also providing, as well as your traditional harm reduction. And they do want to be and will be connected into the national mission workforce discussions that we need to have. We have thousands and thousands of volunteers in Scotland right now providing support, giving back in relation to their experience from a peer support level in relation to supporting other people coming through that journey. And I think that's really important to recognise that as we move forward. It's potentially an unvalued, unresourced workforce. And recovery communities have clearly told us that they are and they will continue to provide those supports in addition to and alongside those treatment pathways for individuals. Yes, what's next? So we're sharing information, we're doing additional research and recovery typologies and what that looks like in Scotland, how those are set up, what makes a good recovery community or a good LERO, if we can start to unpick that. We're doing specific work in women in recovery that we've identified as a gap, and we're feeding all of this into the national mission discussion. And I think that's me, and I think my timing's okay as well, Kirsten.
Thanks, Tracey. Perfect. That's a brilliant bit of work. So thank you so much for sharing that. And I'm sure there will be some questions on it that we'll come back to. I've certainly noted a few things to follow up on when we have the chat. So thanks so much. And I will pass over now to Claire Muirhead. Claire is from Glasgow City Alcohol and Drug Partnership. Thanks, Claire, and over to you.
Hi, thanks, Kirsten, for inviting me along today, and thanks, Wes and Tracey for your presentations there. It was absolutely brilliant. Yeah, so as Kirsten said, I work for the Glasgow City Alcohol and Drug Partnership. I've been there for just over 3 years now. You know, and I am incredibly proud of the recovery communities in Glasgow, Scotland-wide as well, but the recovery communities in Glasgow have a very special place in my heart. and I wasn't going to start with this, but I am, because I was listening, Kirsten, to what you were saying at the beginning about the being kind of, uncomfortable using that kind of word recovery, and how recovery, communities have this real that kind of dichotomy with harm reduction and recovery, and it makes me really, really sad. And you know why it makes me really, really sad? It makes me sad because I know, having been part of the Glasgow recovery communities, and I know many people who are in kind of abstinence-based recovery, which is my kind of own kind of mode. And I know so many people, who not only like work in like, the kind of harm reduction services, who work, say, in the safer drug consumption facility, who work in the, the homeless, residential settings, who work, in the alcohol and drug recovery services, who work in stabilisation and in the kind of crisis, the crisis centre. And these are people who very much understand the importance of meeting people where they're at, getting alongside people, and that their experience, they may be an expert in their own experience, but they're not an expert in anybody else's experience. And what you can do is just walk alongside that person, gives them the choice and the options to make their own decisions. And what makes me really, really sad is the fact that it's those that shout the loudest, it's those individuals who the media kind of go to, for statements about any kind of new developments or any what they see controversy, and it taints all those other people, who are in the recovery communities in Glasgow, where that is not what they believe, and it's certain people, certain individuals who are representing themselves as the voice of the recovery communities in Glasgow. And that makes me really, really sad and really, really frustrated. My own experience with recovery communities, I came into Glasgow just around the time that, the recovery communities were just really kind of exploding in Glasgow. It was the Raft had opened in the Gorbals in 2011. It was the first like recovery cafe in Scotland. And I came into Glasgow about 2012, and things were just, seeds were being planted, and the ADPs were supporting, the recovery communities to open kind of cafes, and back then, I got involved very quickly, and it was, the in the south, I was in the south, and we had like 4 kind of separate constituted community groups, that were all kind of running independently of one another, and getting involved with the kind of opening of one of those kind of cafes, and then developing it into the South Community Recovery Network as it is known today, and kind of gaining charitable status. And alongside that, the Northwest Recovery communities, they were growing and opening up, cafes in localities and the communities. North East recovery communities is the same, we were all kind of, all these volunteers are kind of just kind of, working away and going out and into the communities, identifying, where the need was, making relationships with people who were from those communities. you know, and it was great, you know, and it really did. It, you know, kind of blossomed, and you know, now today within Glasgow, it's just, you know, there's so many recovery communities in Glasgow. You know, I think, you know, what Tracey was highlighting there is, you know, there's no kind of set definition of, you know, what a recovery community is or what it looks like. You know, there could be different models, but I think really at the essence of it is that, you know, it's that peer support. You know, it's people with lived experience, or you know, supporting each other, you know, to grow. You know, and you know, today there's I mean, I wouldn't even be able to count the number, you know, in Glasgow at the moment. You know, I support the ADP Citywide Recovery Subgroup alongside various other work streams, you know, and we do have, you know, the amount of kind of organisations, you know, that are coming together and, you know, and sharing information and getting involved in identifying, you know, what is needed in Glasgow. It is, I mean, it is, it's, you know, it's kind of inspirational. And as Tracey was saying as well, you know, the recovery communities aren't at the end of the journey. They're very, very much kind of integrated, you know, through national mission money, you know, the recovery communities. So there's the three kind of main ones in Glasgow. And when I say kind of main, it being as, you know, the kind of ones that have been there for the longest kind of periods of time, but are also the kind of commissioned recovery communities in Glasgow, were able to kind of get funding and employ 2 outreach workers per sector, you know, and those outreach workers are absolutely, you know, essential to the kind of the work of like the statutory alcohol and drug recovery service. You know, they will, you know, engage with people wherever they're kind of at in their journeys and support them through the kind of treatment and care system. They will, you know, introduce them to kind of recovery communities or any other kind of support that they're looking for at that time. And I think what is essential is that quick, easy access back into treatment. You know, if there is, you know, a kind of relapse, or if somebody's not coping on their kind of levels of kind of medication, you know, they will kind of quickly kind of able to get them back into the statutory service. You know, and I think even that in itself, you know, it goes a long way to show that these aren't people who are, you know, stigmatizing people who are using substances. And a lot of what's in the media at the moment is doing that, you know, especially when it comes from people with their own kind of lived experience as well. You know, I find it really difficult to understand. But yeah, absolutely integral. And, you know, I think we do have to remember as well that you know, the recovery communities are very much made up of volunteers, you know, who do a lot of work in their own time. You know, and for those volunteers, for myself, when I was volunteering as well, you know, it really was. It was that way of, you know, being part of something, you know, and being part of that community, that sense of belonging, and actually then building self-esteem and confidence by doing kind of taking on different roles and responsibilities, to be able to come to a place where, you know, I was able to move into employment, you know. And that is another thing that's quite often kind of quoted, that that Glasgow or Scotland actually as a whole don't really employ people with lived experience, which completely baffles me, you know, because, you know, the people who are, you know, engaging with the recovery communities, you know, whether, you know, they're still maybe actively using or consuming alcohol or substitute medication, these are the people that are going through that pathway of building support networks, building self-esteem, gaining qualifications, And these are the people that are going out into many of the organisations in Glasgow that make up the recovery orientated system of care. And these are the people that, you know, are our workforce. They're, you know, they're the future workforce, and they're very visible to see. So I think I'm kind of ranting a wee bit here now, so because there's just so much. I mean, you know, the recovery communities were involved in the first kind of peer naloxone programme, that is continuing to date. You know, going out to, you know, homeless accommodations and providing naloxone, quite often being the first point of contact for people. You know, where they can actually maybe even find out about what's available for them. You know, there's some really good work going on with the Humanising Healthcare, which I know is supported by the Scottish Recovery Consortium, you know, where there's, you know, volunteers who are, you know, going and speaking to the medics, you know, and sharing their experiences about addiction to try and inform the future generation of GPs about, you know, how to deal or how to support people who are using problematically. We also have, you know, the freed up events, you know, the you know, Glasgow ADP commissions, the you know, the freed up post to deliver, you know, alcohol and drug free nights in Glasgow. Now this started in the Northwest recovery communities, you know, where it was kind of affit nights that were put on by volunteers, and you know, that's grown as well, and through all these things it makes, you know, recovery more visible, you know, and people are seeing that, you know, yes, it doesn't need to be you know, life doesn't stop, you know, if people stop using substances. But what we have to be doing is like supporting people at all parts of the journey. The you know, the volunteers who've been involved in the ADP lived and living experience reference groups have been very much involved in the Thistle development, you know, involved in the recruitment of the posts into that, you know, and are very much invested in, you know, the success of that service and how it, you know, continues to kind of, you know, support people who are, you know, very vulnerable. And I think I might have gone over time there.
You're absolutely fine, Claire. Thank you very much. That was really great, and to hear your experience and what you brought to that conversation. I was almost wishing that I had my camera on so I could be nodding along to a lot of the points that you were making there. So thank you, and I'm sure there'll be more that comes in terms of the discussion with the panel. So if I could ask just my fellow panelists to rejoin me. Please, that would be great. Thank you all. I've been frantically writing as you've all been speaking as well, just thinking of some things also to talk about in this session. And I see that there are a couple of questions have come in. So please, folks, when you're listening in, if you can start adding in some questions and we'll try and get through them. And while we're waiting for you to do that, I'll ask the first one because it relates to one of the questions that's come in. Most of you, if not all of you, talked about meeting people where they're at. And, you know, it's a phrase that we all use. And recently I was at the International Harm Reduction Conference, and Sam Rivera from New York talked about this phrase and sort of challenged the rhetoric around that about the sort of disingenuous approach that often that it can have when we say, oh, we're meeting people where they're at, but often there's a hidden agenda there because we're saying we're meeting people where they're at, but we're really trying to push them towards a particular path or conformity rather than truly honouring people's autonomy and their own personal goals. So there's a question around treatment, and Tracey, you talked about it in yours about sort of pathways out of treatment for people. So my question is, how do we, sorry, it's not my question, but it's been informed by a question that's come in. I've reframed it a wee bit. How do we support people to come off treatment when and if they choose to do that without creating the pressure that end in treatment is the ultimate goal or it's a measure of success. Because often we create this narrative where people would only feel like they were doing well if they were not in treatment, where actually, should we be more reframing the narrative that you can be recovering in other areas in your life and still be on a prescription, for instance? So I'm just keen to hear people's thoughts on that. I don't know if anybody wants to jump in first, or I'll choose someone.
I'll jump in
Thanks,
if that's
Wes.
all right. I think for me, if people are getting some level of holistic therapeutic support and looking at all areas of their life, and my own, I guess, experience kind of marries up with this a bit. As the other well-being was improving, then I wanted to look at reducing and stuff, if that makes sense. It was almost like a natural progression to start thinking, oh, actually, I've got some good stuff, positive stuff, I'm engaged in things, and it might be other activities. And I think for me, when that's done in a really truly person-centered way, usually I often, I guess, phrase it like, if you look after the relationship, the outcomes will usually look after themselves, and the outcomes as defined by the person. But often you'll be ticking or meeting other outcomes that you didn't set out to meet, if that makes sense, if people are getting that kind of therapeutic support and support to engage kind of elsewhere that they want to. And I just know from my own personal stuff, when it always seemed to be the focus on the substances and the urine tests or the medication and the dose, it really invoked a kind of resistance from me. Like, I was sick of it. I was never asked, how did I get here today? Did I eat yesterday? Have I had a shower? How's your drug use? How's your drug use? How's your drug use? How are your sites? How are your sites? And I think if people started asking about some of the other stuff, I would have been probably more willing or open to opening some of that stuff. So for what it's worth, I think that's my take on some of that.
Thanks, Wes. Tracey?
Yeah, thanks. And I suppose that it's quite good to be challenged around that phrase, Kirsten, and meeting people where they're at. And I suppose from the work that we've done, recovery communities and lived experience organisations really authentically try and do that. So I can't talk for the treatment system in relation to some of the other subliminal things that are going on there in terms of pushing people in a certain way. So it was just for me, that's what recovery communities have told us where they're at in terms of the pathways out of treatment if people choose that. I think there's something in what Wes has said, and that's what people tell us all the time. You can be in treatment and still having really positive elements of your life that are moving forward. So we created this culture around, I think, some of this discussion, Kirsten, and I think it's really important that we're starting to unpick that and reframe it. There's something for me around, in my experience and the people that I engage with in recovery communities, when someone tells you they want to try something new or make a small change, what's really important and it's really, really clear in terms of behavioural on a human basis, a human level, but the research clearly tells us the relationships you have with people, whether it's your addiction worker, whether it's someone in recovery, those relationships are so important to be a really good predictor of positive outcomes. And that is absolutely crystal clear in everything that we've looked at. And from a human base, and from a human point of view, that is absolutely crystal clear as well. So I think there's something about when someone tells you, I want to try something different, it's like, okay, what does that look like for you? Let's try it. But not to have this stigma attached to it. Well, if it doesn't work, it doesn't make you any less of a person, because you can still have elements of your life that are working really well. And we've created this dichotomy, haven't we, that if you lapse in this part of your life, or if you do something in relation to your drug use, then that means that you have lost everything. You've not, because there's so many other elements of your life that are holding all this together. So I don't think it's one size fits all. I think it's about making sure that you're working with people in relation to supporting them. Relationships are so important, not being stigmatizing in relation to the choices that people want to make, and to try and change the narrative around sometimes things don't work, but you then go back to say, well, why didn't it work, and let's try something new. And that's what I mean by working with people where they're at, Kirsten. I hope that makes sense.
Yeah, no, totally. And it made me reflect on my own language, because it's something that I talk about all the time, meeting people where they're at. So now I've started saying, unconditionally meeting people where they're at, just to try and reinforce that bit about, like, yeah, you know, that we shouldn't have any ulterior motives for people, and just going and being led by the person. Claire, I don't know if you wanted to add anything to that.
Yeah, so I was actually just kind of reflecting on, it was, you know, several things like 2016 or something, and I went over to Lisbon, and I went out and visited a project. It was in Moraria, it was called, and I remember there was, you know, people there who were working there, who were still on kind of methadone, but there was no kind of plans or anything about to come off it, and they were on their medication, and that was it, and they went to work, and that was just fine, that was accepted, you know. And I think we do have to, like, and, you know, look at ways of allowing people to make their own choices, and I think that's really what, you know, recovery should be about. It's about empowering people to make their own kind of decisions, and, you know, and supporting them. But I get what you were saying about that, about how do we have intentions, you know, is it meeting them where we're at and thinking about it, and yeah, and I think people do need to really think about that. What, you know, just kind of actively listening to what the person wants. So yeah, I think there's a lot of stigma for people to be on kind of substitute medication, and I think there's a lot that needs to be done to kind of change that.
Grand, thank you. There's a question in that sort of relates to something else that I was thinking while you were talking. And it relates something you said, Wes, about, you know, how do we make those environments inclusive when we recognise that for some people in early abstinence-based recovery, it could be difficult being around people who are still using substances. So I guess the question is, how can we develop recovery communities to support people at different stages, regardless of their substance use? Because if we want people to have that sense of connection and, you know, that sort of hope visible and all of that stuff, how can we develop the recovery communities to make sure that they are inclusive? I don't know who wants to. Oh, I know I was mentioning you guys because it's came up in your thing, but Tracey, maybe there are examples of that nationally as well that you could reflect on.
Yeah, so how do we make recovery communities inclusive? I think there's something around, it's a really fine balance, because people in recovery and recovery communities and the areas that we speak to is, if people are stable or they are in treatment and they potentially want to be around people who are also stable, then there is a real fine balance, because actually individuals who are more chaotic coming into that space can create a trigger. So there's a range of different things that are happening across Scotland. So there's low threshold recovery communities where there is more people who are still actively using than not. There is recovery communities across Scotland who have a hub and a spoke approach, so actually they have a recovery hub, but actually those individuals who are still actively using are still using harm reduction, a range of different prevention elements and prevention approaches. They can still access that, but there's also a space where there's clearly people telling us in recovery that they need a safe space. So, and I think I've seen one of the questions coming in the chat, it's, we can't narrowly define recovery. We can't do it because it is just so individualised. But one thing that can work, Kirsten, in relation to that is low threshold recovery communities is like, come in where you're at, and you'll see this with the work you're doing with SDF and these people you speak to all the time. So it's about come in where you're at, have a cup of tea, no stigma, nothing attached. Do you need a bit of support? Do you need somebody to chat to? Yep, I just need a cup of tea and I'm off again. Great, super duper. So I think we need a range of different things, and there is a range of different things happening across the country, and the typology work will start to unpick something.
Thanks, Tracey. Anyone else want to come in? Wes, Claire, do you want to add to that?
Yeah, so I think, you know, it has always been a challenge about kind of getting that kind of fine kind of line and around, you know, if somebody's kind of overly sedated or maybe overly intoxicated, then that can obviously have that kind of negative effect. But I think it's about people who kind of attend, and it's like, right, obviously with problematic drinking, people have to be drinking, it's not, but I guess it's like just trying to kind of manage those situations on a person by person basis. And I mean, I think I know that the recovery communities will go over and speak to, the men and women who attend like the sex ed and engagement group, and who are mainly still kind of using substances and alcohol, and even just having that kind of point of contact, that that recognisable face, is kind of encouraging them to kind of actually go along and see how it is. But I do think in Glasgow there is kind of more kind of need for a space that is that people who are actively still using. Obviously we do now have the kind of thistle, but that's only for people who are injecting substances. But even within the kind of thistle, we're starting to have kind of conversations about activity-based groups or something, or walking groups or something that people can get involved in, because it is really important for people's kind of self-esteem and their confidence, and to be able to kind of just grow that they've got activities and things that they can actually do that they enjoy doing.
Thank you. I just want to read out this quote that's came in on the Q&A as well about the Cafe Connect service, because the group themselves came up with a definition, so I just wanted to share it with people. Recovery within Cafe Connect allows us to make new connections and meet like-minded people, learning about our rights and discovering our talents. This empowers us and helps us fight stigma and stereotypes. We realise our value and improve our well-being, our confidence grows, we feel positive, and we look forward to the future, which I think's a pretty good description that they've obviously come up with themselves. And then it relates to another question that's come in and something that I'd had. So I know we were talking about not being too prescriptive around what recovery is and defining it too narrowly. How do we feel like we could make the recovery language more inclusive, so that we can, create that perception, not just the perception, but create the reality that it is not just for people who are abstinent? So how can we make the recovery language more inclusive?
Kirsten, just to come in, I think what we're doing now is making recovery language more inclusive. These discussions, these challenging ourselves, challenging the culture we've created, challenging our thinking in itself is going to make the recovery language more inclusive. There's a range of definitions that you could look to in terms of recovery communities, recovery capital, recovery assets. And I suppose for me, I would be happy to look at this from an SRC perspective, but what that definition needs to be shaped by the people who are actually in recovery communities and have that lived experience. It cannot be created by, no offence to our government colleagues, but civil servants or those in other parts of the system. It needs to be driven and created by people with lived experience and people who are actually, and living experience, people who are actually in our communities. I think it's really difficult to define it into one or two sentences, and that's what everybody's told us that we expect. We stop defining who we are. We are members of community. We are your neighbours, we are your friends, and we are your family. So can you please stop defining this into a couple of sentences? And I think that's important to listen to. But I'd be up for a challenge if anybody, a group of us, want to get together and try it.
Yeah, I'm not volunteering, because I think it's that flexibility piece. Like we've talked about flexibility throughout the whole thing, and whilst that can be frustrating as well, and often we want to create these sort of definitions, it's actually the flexibility that helps it become more nuanced and more individualized. Wes, did you want to add anything?
Yeah, I was just going to say, I think for me, sometimes it's about being very clear and not substituting language or using the word recovery if I mean, or if I'm actually talking about someone who has stopped using, and trying to just differentiate a wee bit, if that makes sense. But I think, yeah, as a bit of an umbrella term, I don't have an issue with it, and I don't think we want to go down the road of trying to reinvent, a kind of glossary of terms and all the rest of it, because then I would worry we would get in the pigeonholing kind of exercise of where what camp are people in and things like that. But just being clear, if I mean stopped using, then I'm going to say that. If I mean abstinent from substances, I'm going to say that, as opposed to saying recovery, if that makes sense.
Yeah. Okay, thanks. There's a few questions around like MAT standards and treatment. So in order to incorporate it into this recovery discussion, I wonder if I could just sort of pull all that together and just ask the question, how do we feel that the implementation of the MAT standards has incorporated that real recovery mindset, if you like, or ethos when it comes to connection and community? How are we doing with that in terms of incorporating the two? Go on then, Tracey.
Me and Wes. I think the MAT standards has been a good place to start. I think it's taken several years, and I think it will continue to take time to embed the MAT standards if we are thinking about a fully recovery orientated systems of care. I don't think we're there yet in terms of has recovery lived experience, recovery communities, recovery organisations been fully embedded into the MAT standards. I think not everybody has the same experience. The benchmarking report has just come out, but that will not be everybody's experience, Kirsten, as they try to access treatment and support for themselves. So I do think the MAT standards is a place to start. I think it's gave us the benchmark, but I do think there is more recognition required, that we've all said today that people need choice and access and compassion. And we need a range of different things, and treatment may be the way in, but actually mutual aid may be the way in for some people as well. So it's MAT standards just one way that we could help people get well in relation to recovery.
Thanks. And it's, sorry, Wes, just bring you in a second, but it's related to that postcode lottery as well, isn't it? Because it depends what sort of services people have got locally as well and what they can tap into. So we talked earlier about, often recovery being seen at the end. So you go through this system and this process, and then at the end you could get recovery and get linked into this thing. But rather than seeing that as, say for instance, the first time a person approaches a treatment service, how are we integrating that sense of connection and community at that very point? And if you are in an area, somebody's commented in the Q&A around how are you meant to move forward when it's impossible to get someone to show you how to get out of that rabbit hole, quote unquote. So if you don't have those communities or environments around you and it's not visible, it's that postcode lottery again, isn't it, in terms of what people actually have access to. Sorry, Wes, I cut you off when you were going to come in.
You're fine. I think there's a long way to go with the mental health stuff. I think that for me is one of the kind of key aspects, is the co-delivering mental health support alongside substance use support and not keeping them separate. I think where the MAT standards, like the first 5, are kind of being implemented and they're done reasonably well, I think one of the benefits is reducing that power imbalance, or that perceived power imbalance between prescriber and patient. And I think for me, that's one of the real kind of sticking points, arming people with their rights. And I think the national collaborative work is going to be really helpful in this too. And I think it's going to help reduce some of that, I think there's a real strong culture amongst people of you get what you're given and you should be grateful, and like don't rock the boat because you'll get discharged. And I think as we see that kind of ebb away, hopefully with the work that's happened, I think that's going to be an important factor. But I think exactly like you said, the postcode lottery type stuff, and when there's not a recovery community landscape locally, it's probably very difficult for professionals to be connecting. They've got nothing to connect people kind of to. But yeah, I always think the psychosocial support element is lacking in treatment as well. Whenever I hear about people being, on any OST for decades, I would always ask the question, are they getting adequate psychosocial support? Because I don't know many people that have been on methadone for 20, 30 years that have been getting decent psychosocial support and connected to other, improvements of their kind of general life. that want to stay in that state, if that kind of makes sense. So I think there's a big part of that puzzle that's not always offered or delivered adequately. And mutual aid, prescribers even mentioning mutual aid to people, and I'd hazard a guess not as often as maybe they could be.
Thanks. And Claire, I guess in Glasgow, because the recovery communities have been around for so long, and they're very accessible across the city. What's your sense of having that availability and how that helps people? Because it's so
yeah, I mean, I think, and obviously I've heard from other people, who've come from out with the Glasgow, and they're just like, gosh, there's just so much in Glasgow, that choice, and I think having that, it's that kind of stickability, with somebody who is going to kind of get alongside you and kind of show you where to go and places to go, and that's where the recovery communities are very kind of good at doing that, and obviously the actual like care managers within the ADRS, they're encouraged to kind of take their the people that are working with along to it. And I think like in terms of kind of the MAT standards, it's I think it has really helped a lot in terms of people understanding what their rights are as well. It's given them, it's empowered them. And again with the Charter of Rights as well, about educating people, and I think the recovery communities are very good at doing that, about letting people know what is going on kind of nationally, and what they can expect. I think that MAT standards kind of 1 to 5 has kind of implemented mostly. I think it's like 6 to 10 is going to take a wee bit longer, but I think what's happened though is it's kind of it's hurried. It's the process has been hurried up. Hurried isn't the right word, but it's escalated a little bit to make kind of things kind of happen quicker than it would. But I think it's also really important that we don't kind of take the kind of eye off the ball with all the kind of different drug trends and the changes that are happening within Scotland at the moment, particularly, with like the cocaine use and, ketamine, and the kind of, a lot of the benzos and the kind of synthetic opiates as well. And I think the services have got a challenging time, the statutory, the third sector, the recovery communities have got a challenging time, and how to respond to all these kind of rapid changes that are happening, and the same kind of standards needs to be open to everybody. Everybody has a right to them.
Yeah. Thanks, Claire. I wanted to come back, Claire, to something that you mentioned when you were talking earlier, about misrepresentation in the media, which is something that happens frequently in the sector. And I just wondered around the impact of that. You said that in terms of the recovery communities and how that has affected things on a Glasgow level. Obviously, the elephant in the room is that the Thistle has had particular negative media attention, which has been so disappointing to see. But like you say, some of the narrative in the recovery communities does not reflect what is being seen in the media. So I just wondered how you manage that. And
yeah. I mean, it is difficult. It's difficult for kind of members of the the kind of wider kind of recovery community, and it's difficult at a personal level as well. It's when how much people care, and how much effort people are putting in. I mean, the harm reduction workers at the Thistle, they're all kind of lived experience, and they're there because they genuinely just want to kind of support people coming in, and then when you hear things like it's a palliative care ward. Or and it's just incredulous. It's like, I mean, I go down to the Thistle for a couple of hours every other week just to kind of chat to some of the people who are using the service, and see how they're getting on, whether there's anything they'd like to see happening and they're not happy about, and it's like the gratitude that these people have for just having somebody who's going to sit and treat them like a human being. You know, it's like, God, I'm actually welling up just talking about it, but it's just like, it's like, every single person I've spoke to has spoke about the fact that, that's mostly the first time in my life that I've ever actually just been treated like a human being. There's been no judgment, there's been no, stigma. They're just kind of grateful for a space to come to, where they're not going to be judged and they're not going to be forced to do anything they don't want to do. They can just come in and sit and have a cup of tea and go, or they can go outside and have a blather and have a smoke and take it. If they want, they can get linked in with housing. If they want, they can get linked in with treatment or get benefit support or just have a chat, just whatever, and it's it's like, when you hear things like, about it being like just a palliative care ward, it's like,
Yeah.
these people are the ones who are most vulnerable in society, who don't normally engage with services, and I mean, my experience, and my experience of other people that I've kind of supported along my years, is that people change. People want something different when they start feeling different about themselves. It's like something internal. It's like that happens, and it's like if you can give people that opportunity just to start to feel a wee bit better about themselves and feel that they're actually valued, to me that's priceless.
That was exactly the stuff you were talking to Wes earlier. So I guess then for Tracey and Wes, then given what Claire's saying, and I don't want to feed into this rhetoric at all, but what does it look like to you in practice to support both harm reduction and abstinence within the same community or even service? What does that look like?
SRC and the people we speak to don't have a problem with it. It's not us that has the problem. It's some external environmental discussions that are going on in relation to this. The recovery communities I speak to and people in recovery at all stages of where they're at is they want to be left alone to do what they need to do to make sure their lives are safe and they're getting access to what they need. Recovery communities and I speak to say that we don't really listen to the rhetoric because actually we know we're saving lives at a local level. And from an SRC perspective, it's really good to have these honest, open, professional discussions. And do you know what? We can disagree and we can have discussions about this, but let's have it in a way that we can actually learn from each other. So I've spoken to a lot of people in recovery and recovery communities at all different stages of their journey, and they know they're doing a good job. They know they're saving lives and they're going to continue to save lives and they're going to continue to support people and they're going to continue to do the work they do on a day-to-day basis. Some of the other discussions and some of the other communications that we're hearing actually detracts away from the really amazing work that we're doing on a day-to-day basis, whether that's personally from an SRC perspective, whether that's lived experience recovery organisations. So we will not be taken away from the work that we are doing. We won't be. And we won't be moved from that. We'll continue to make sure that we are continuing to save lives on a day-to-day basis, whether you're in harm reduction, treatment, whatever that is. And we'll continue to do that. And that's what recovery communities are telling us. It won't stop us. But they feel a bit discouraged about this representational view that everybody's the same. So the same way we can't define someone's recovery journey, we can't define a whole national population of people in the same way, Kirsten. So I hope that makes sense.
Yeah, and thanks, Wes.
I'd like to think it looks exactly the same from my perspective. Like if I'm turning up at a mutual aid to try and offer a bit of support or to just be a part of that community, or if I'm turning up to do naloxone training, I'm going to treat everybody I meet the same. I'm gonna try and see where they're at. I loved what you were saying, Claire, about that. I used to phrase it as unconditional positive regard. And for me, the chat and the lingo, or if they're asking for any suggestions, might look a bit different. If they've determined or they've identified they want to move towards abstinence or maintain abstinence, then that might look a bit different, the interaction, to someone who, you know, might be trying to reduce injecting or get a roof over their heads or get fed for the day or whatever that might look like. It's people, and I think that's where the magic happens. It happens in the interactions, and I love what I've heard really about the, you know, some of the optics and some of the stuff on social media. I've come away from a lot of that. It is never going to detract me from the way I operate and the way I do my work. I believe very firmly, you know, I'm open to have discussions, and I've hopefully shared reasonably articulately how my belief system has changed over the last 5-10 years and how it can continue to change. And I love those healthy discussions. I think that's really important. You know, often I come across people that are really quite dug in and entrenched and embedded, and they've got the sandbags up, and, you know, harm reduction doesn't work. And I just usually ask, define work. What do you mean when you say, oh, what are you doing that for? It doesn't work, or naloxone, it doesn't work. Define it doesn't work for me, and then we'll have a bit of a discussion. And they normally flounder a wee bit then, if I'm perfectly honest, you know. And I think it's bringing that own personal, what might have worked for you or where you might be now in your life. That's brilliant, and I commend you for it, and more power to you. But we're talking about other people that are in different positions and in different scenarios, and it's quite arrogant. I find it quite arrogant to try and, you know, preach what worked for me to someone who might have a very, very different history, and they might have very, very different struggles and a very, very, you know, a much bigger hill to climb to. And I think that comes back to what I was trying to describe earlier about people's starting point. And it might look very similar on the outside. Some of the external factors might look very similar, but we're, you know, all weird and wonderful, unique humans. So when you take that into account, you know, redefine work and try and come alongside the person. Values-based. I don't think you can go far wrong if you're working off a values-based kind of belief system.
Thanks, Wes. So we've got like 1 minute before I have to wrap up. So it's been a really excellent conversation, and a lot of people are commenting to say that, you know, it's been really good conversation as well. So, but one of the questions that is there right in my eye line is where do we take this discussion now, and how do we keep the energy going around this? So I don't know if anybody's got any final thoughts around that just before we close.
Quickly, from a national perspective, SRC, the national organisations, SHAP, Alcohol Focus Scotland, ADPs are continuing to have this chat. We are continuing to challenge ourselves. We are continuing to challenge government. SRC conference was just last week. We'll continue to have these discussions, but we need to start. We need to start getting this on a bigger basis. Kirsten, and if there's anybody in the chat that wants to connect in with SRC, throw them my details, because I know there's been a couple of questions.
I'd say keeping the conversation going when there's opportunities arise to do it, and be open to listening to other perspectives, good, bad, or indifferent, you know, and because you can always circle back and stick with your belief system. But I think, yeah, just being open-minded to have some of these discussions is helpful.
Thank you. Claire, any 10-second last thought from you?
Nope, just look after yourself and look after others. Self-care is really important. And yeah, thanks for having me.
That's a lovely note to finish on. So yeah, just a massive thank you to everybody who joined today's webinar. Our team have put in the chat there that this webinar has been recorded, so it will be available on our YouTube channel in due course. And please do complete the automated evaluation that comes up. I would really like to hear from you about this conversation and any thoughts that you have for us going forward about what you'd like to hear more of. So thank you so much to all the presenters today. That's been really brilliant, and we look forward to keeping this conversation going, like you say. Thank you.
Thank you.